Dr. Lin, at the Glaucoma 360 this year, you presented a talk on the new advances in cyclodestruction. Can you elaborate on what your presentation was about?
Yes, I talked about some of the newer technologies. This includes endoscopic cyclophotocoagulation, which has been out there for a few years now, and also about the relatively new micropulse technology for transscleral cyclophotocoagulation. There's been a lot of buzz about it because it's relatively easy and in most people's hands it's been very safe. The efficacy has been variable among different users, and I think some of the differences has been that some users may change the protocol a little bit. I, for example, do a little bit more treatment than is the recommended treatment. Our results from our group, we've looked at it, we actually have that submitted and it's in revision at this point. We have about 68% efficacy in lowering the pressure 20% or more. We've treated all the way from mild to severe and refractory glaucoma, and we found that, again, about 2/3 of the time we will get a good response, and given a relatively safe procedure, we found it to be a good sort of almost like first-line surgery in many patients.
What's interesting about that, the whole concept is I've been following and I find it very interesting glaucoma treatment. How does it differentiate? Now, this might be very basic, but I think a lot of our readers may not understand that. How does it differ from, say, a stent? I know obviously you're more laser oriented, but how is it in terms of outcome? Is it better or that you're a stent or with the equivalent to a stent?
Right. There's no direct comparison studies, of course, so we're going by different studies and trying to compare them in our own experience as well. There's quite a bit of difference. It's not an intraocular procedure where you actually have to make incisions in the eye, have a risk of infection and bleeding inside the eye. So that's a major difference in terms of the safety aspects as opposed to eye stents or these newer ones such as CyPass surgery, which are getting a lot of buzz. And so it's done all externally. The mechanism of action is somewhat controversial, also very interesting, whether it decreases the aqueous inflow, the cyclodestructive aspect, or does it increase the aqueous outflow through a uveoscleral mechanism, which has been postulated. So that's been very interesting. In terms of the efficacy between them, again, some of the stents, for example, may not work in some patients, similar in this case, and it's hard to predict who that is, right now from the data that we have.
How about in terms of patient selection? Is there a specific kind of glaucoma patient you're looking for when you buy a micropulse?
Well, let me talk specifically about cyclophotocoagulation in general. With the general, existing diode cyclophotocoagulation, you could call it sort of the older type, it's usually reserved for the sort of end-stage, blind, refractory glaucoma eyes that are very tough to treat with very high IOP. We still have used those, have used the micropulse in these cases as well, but now the indications have really expanded. So I've done it in patients who are, on just maybe 1 or 2 eye drops, but they can't use other eye drops and have more mild glaucoma because of the safety profile. The micropulse technology sort of takes that laser energy, which might cause a lot of damage to the eye, and breaks it up into little packets of energy with relaxation times in between so you cause less damage.
So my last question is, what's the take-home message for the clinician?
Well, I think for the clinician, it's possible that they may want to adopt this new technology for their treatment of glaucoma. Again, any new technology will require experience and patient selection, as you said, and the right patients in terms of their willingness to tolerate more high-risk operations versus lesser risk operations. But there may be a chance that it may not work. As I said, maybe about 1/3 of the patients, it may not significantly lower the eye pressure.
Thank you, Dr. Lin. Appreciate your time.
You're welcome.